Okay, everyone, well, welcome to this July South Warwickshire University NHS Foundation Trust board, but this is also the 75th birthday of the NHS, and I know the phenomenal work that goes in, day out, to deliver the very best care that we can at SWFT for the citizens of South Warwickshire. Today is also a special day because the anniversary celebration is being recognised at Westminster Abbey with a special event there with members of the NHS invited. Three members were invited from SWFT, and Glenn and I decided to send previous Going the Extra Mile winners, Charlie Wilson, Suzanne Bullymore and Claire Scotton. So we're delighted, and we hope that Charlie, Suzanne and Claire have a wonderful day and tell us all about it when they get back. So with no further ado, we'll get into the main business of today. We've had a busy morning already, so the members of the public are aware. We've had an excellent discussion on our children's paediatric services in the community. We've discussed with Health Watch some of the key trends. We had Chris Bain, the Chief Executive of Health Watch Warwickshire, come and join us and talk about the concerns of our citizens to make sure we were fully sighted on them. Had a good discussion on future possible developments at Stratford Hospital, a bit of an update on finance and trends on finance, and also Charles led us through a deep dive into mortality analysis. We were due to be joined by colleagues from the urgent and emergency care, the intensive care department, but they were very busy. So we look forward to seeing them again in the future, but appreciate their hard work in the meantime. So apologies for absence come from Bhaskar, who's on holiday, and Gertie McPhillips will be joining us in due course. Are there any new declarations of interest? Could you please raise a digital hand, Director colleagues, if that is the case? Can't see any hands raised, so we'll move on. The minutes of the meeting held on the 7th of June. If there are any points of accuracy on those, could you please raise a digital hand? Okay, I'll take them as correct. Then the minutes of the extraordinary meeting held on the 20th of June. If there are any points of accuracy on that, again, could you please raise a digital hand? Okay, can't see any digital hands raised, so I'll take those as accurate. So we'll then move to the action points arising, and we go to page 23 of our pack, and there were just a couple regarding the IPR. The first was for Harkemel to brief me with any further updates from the system with regard to equality and equity for patients using oncology services. That update was provided. We will cover it today. I think there's been some very helpful work that's gone on over the last 4 weeks, and I know Charles and Harkemel have been intimately involved in this to ensure that the potential for differential levels of speed of seeing an oncologist within Warwickshire and Coventry, I think we're feeling more assured on that, but there still is the underlying issue of a shortfall of capacity on oncology services, not least driven by the very real increases in demand we've seen over the last few years as the NHS has invested more and more in diagnostics. So we will continue to keep you briefed on that. And then Charles was to raise the question with systems concerning the potential for buying private sector capacity to improve the waiting time for oncology patients. And that question was raised, and we're awaiting an answer from the system. Are there any action points arising that colleagues feel I have missed? Okay, so I'll move on to then my chairman's remarks. Now, this is included to allow me to update you all on the ICP, the Integrated Care Partnership meeting, which met yesterday. Unfortunately, I was in a George Eliot board yesterday, so Simon Page kindly attended on my behalf. Simon, are there any particular points you'd like to brief us all on what came out of yesterday's meeting, please?
Of course, thank you, Chair. I think there are probably 3 points that are worth making. First of all, I think there was a strong and encouraging representation from a broad cross-section of all the system stakeholders, and they were all very keen to work together, and there was a strong intent to do the right thing for the public within the system. So I think that's all very positive, and to address the health inequalities. I think my observation would be a number of KPIs were signed off and some actions were taken, but it strikes me this meeting is still finding its feet, and with such a broad cross section of stakeholders is always quite a challenge, but it really has got an objective to make sure it does find practical outcomes from the discussions it's having, and I'm sure in time that will be the case.
Okay, thank you, Simon. We look forward to the pace across the ICS picking up to ensure we do get really the full benefits of the high quality assets we have across Coventry and Warwickshire. Any questions to Simon from director colleagues? Okay, so we therefore will move on to some items for approval. And as all of the board are aware, and Governor colleagues are aware, we have been considering the proposal to expand the foundation group. We have a paper on it today, which requires approval of the board. Glenn, over to you.
Thank you, Russell. So the paper that in front of you, I won't go through all of it. It frames the rationale for consideration of Worcester Acute joining the foundation group. I mean, firstly, to say provider collaboration is a fundamental element of the latest reforms in the NHS. The strongest forms of collaboration are those where there are shared leadership models, and indeed as a group we're seen as leading the way in the development of a group model that isn't about organisations merging, but is about organisations collaborating in a very powerful way. About 18 months ago, Worcester Acute joined us as an associate member of the group, so they have been sitting in on our group strategy meetings. But an opportunity arose when their chief executive announced that he was moving to pastures new for them to consider full membership. So over the past couple of months, Russell has discussed with them the way that the group works. And I think it's fair to say there's a lot of support from lots of stakeholders for them to formally join the groups. The process that they've gone through has been for a paper to go to their board meeting last month, and for their board to agree that they want to approach us to be full members. So this paper, a version of this paper, went to George Eliot yesterday board and was supported by George Eliot board. It goes to Wye Valley board tomorrow. And that's the way that we work, because we're sovereign organisations, so each trust needs to say they're comfortable with this in order for this to move forward. But should it move forward, then we would move quite quickly, because the nature of the model is you can move quite quickly to put in a situation where they're formal members from the 1st of August. That would entail Russell and I being their chair and chief executive, them having the group strategy committee as a formal subcommittee of their board, and then us continue to work together in the way that we do with other foundation group members. The scale change will be an organisation which joins together to be just below £1 billion turnover to just above £1.5 billion turnover, and that brings with it further opportunities of scale for the group, but more importantly, further opportunities to look at an organisation and share best practice. Whilst Worcester has its challenges, it also has some great services, and I'm sure we can learn from them in the same way that they will learn from us and Wye Valley and George Eliot. So that's all I wanted to set out, Russell. The formal process for us would be to, if we agree to this, also to agree to the change to terms of reference for Group Strategy Committee to bring them in as full members, and that's what's set out in the paper.
Thank you very much, Glenn. And I think just in terms of the citizens of South Warwickshire, many of whom around the Stratford area would naturally go to the Alex on occasion. We've discussed in the past, particularly during winter pressures, the way we've had to support Worcester Acute. And thanks again to our ED department for the extra efforts they've gone through. But this is also an act of enlightened self-interest. As I said, we have discussed it a lot in the past as a board in private session. Are there any questions on the proposal? So if you're not happy to approve, could you please raise a digital hand? I can't see any digital hands raised, so I take that as a formal approval by the board. As Glenn said, it is going to the Wye Valley Board tomorrow, and if formally approved, then it will then be implemented from the 1st of August. So we will keep members of the public briefed. It's clearly going to create some challenges for Glenn and I, but we are both absolutely convinced that this is the right thing for us to do for the people of South Warwickshire, the right thing to do for the Foundation Group. And in a national health service, it's absolutely the right thing for us to be doing for the citizens of Worcestershire. And we believe that them becoming full members of the Foundation Group can help accelerate the good work that they've been doing on improvement. But there's a need to change that trajectory. Okay, thank you, colleagues. We'll then move on to the Data Security and Protection Toolkit, the DSPT assessment. Charles?
Yes, the paper I think we can take as read, but the team has done extremely well to be able to achieve full compliance with all the standards. And I can add actually that we've exceeded them. We got notification that we were given an exceeded standards for our Cybersecurity Plus implementation. So, you know, not only all achieved, but with a commendation.
Thank you very much, Charles. That's very assuring. Any questions or perspectives on the DSPT report or assessment? Everyone happy to approve? If you're not, please raise a digital hand. Okay, duly approved. Thank you very much. So move on then to the Chief Executive's report. Glenn, over to you.
Thank you, Chairman. There's so many things in here I'd like to talk at length about, but I'll try not to. The report starts with an update on the community hospital bed review. And in fact, unusually, I've included the entire press release that we issued on this. Rather disappointingly, the story was covered by the Stratford Herald newspaper a few editions back that gave quite a misleading picture about what was happening in terms of the recommendations that we put forward to the integrated care system. So the full press release is here. In addition to that, actually last week I attended the Health Overview and Scrutiny Committee of Warwickshire County Council and had the opportunity to talk through the rationale for this there, which is a really clear rationale. Obviously, we discussed as a board previously, which is consistent with our strategy around trying to ensure that patients receive as much care as possible at home or close to home. Doesn't believe in using beds unless we absolutely need to. But actually, the beds that we then do need for step down need to be located close to the biggest areas of population. So the review has concluded that we want to, despite the fact that the modelling said 19 beds we maybe could be okay with, we as a board felt a little bit uncomfortable with that and went for a higher number. But the locations of those beds are proposed to be in Leamington and Stratford, where the biggest centres of population are. In fact, following our previous board discussion on this, because time moved on a little bit, we've updated the data on usage and demand for community hospital beds. We've put that onto our website yesterday, actually. Maybe we'll do a bit more press on this, and it reconfirms what I've just said, that the by far the biggest demand is in the kind of Leamington, Warwick, Kenilworth and Stratford areas. And indeed, it would be not delivering the best care to our patients to ask relatives to travel all the way from Kenilworth into Shipston, for example. So that heat map of demand is there. The process of this review is that, and actually I should say that the Stratford Herald did report on my health overview and scrutiny committee presentation more fully this week, so that's good to see. So that recommendation is with the integrated care system. They need to decide whether they should or shouldn't go through a formal public consultation. There was a lot of engagement on this review. We took advice. We involved Health Watch Warwickshire, but it's absolutely the call of the integrated care system to determine whether they need to do that. So moving on, Further Faster is the name of the outpatient waiting time improvement programme, and we're well and truly in that now as a group. So we're looking at individual specialty workshops now, where we use the Getting It Right First Time data to seek ways in which we can improve our outpatient productivity or protocols. We are also looking at inpatient productivity as part of this, and I'm very sure that the work of that programme, together with our excellent clinical and managerial teams, will deliver some better results for us. And what we seek to do through this is to deliver earlier than the national expectation, the 52-week wait maximum. And we'll look at our performance data later, and you can see we're well on the way to do that. I then talk about National UEC Recovery Plan, and there's some more guidance coming out on that, which will be available for all trusts, not just those who are under performance management arrangements at the moment. So I've had a look at that because it's and it looks really useful, and we'll be using it as part of our kind of winter planning. Provider Collaborative Innovators. This was also presented by our team to the Midlands Provider Collaborative Forum last week, and it's good to see work progressing on how we can move more rapidly to the lead or host provider role in each of the trusts in the group. That's another area that our Worcester Acute colleagues are very keen to learn from and seek to implement. CQC maternity report, we haven't had it yet. But we're looking forward to that report becoming available, and as soon as it does, we'll bring it to one of our board meetings, and obviously it will be publicly made available by the CQC. But that followed an inspection a few weeks back, and those inspections are taking place in every single maternity unit across the country on the back of the Ockenden report. There's then a section on the ICB meeting, and I included Appendix A, the letter following the most recent review meeting. And then I turned to NHS at 75. As Russell said, it's today, and we've all got our screens behind us showing the celebration for that. And it's great to be celebrating the success of the NHS and the things that we've achieved over the years. I reflect here on 40 years in the NHS, which will be a milestone that I'll be going through very soon. And it's great that our frontline staff have been able to go to Westminster today to be part of those celebrations. Our frailty team are also at number 10. They've been shortlisted for a National Parliamentary Award. And they're just a typical example of lots of great services that we have locally. Our presence as an NHS from the current government is an NHS workforce plan, and that came out last Friday. So I was speculating about it when I wrote this report. When we meet next month, we'll have a little bit more of a thorough look at that report. There's some headline announcements about significant increases in training numbers for all sorts of clinical disciplines, which is really welcome. And by the time we next meet, we'll be a little bit clearer on where the funding is coming from to allow us to do all of that. Then there's a section on our infection prevention team, who were a tremendous part of our response to COVID. and that explains how they work and how they'll continue to keep us safe as we move forward. And then the usual list of visits from board execs and non-execs to departments. So I'm happy to take any questions, Chairman.
That's great. Thank you very much, Glenn. Questions and perspectives to Glenn? Stand us all in silence, Glenn, with that. Okay, so we'll move on then to the integrated performance dashboard, which I know just covers May. Before we get into the detail, Adam, I just do want to put on record my enormous thanks, particularly to the ED team who have been coping with some quite phenomenal volumes during the month of June. I think I'm correct in saying that we recorded our highest ever attendance into the ED in June at 387, I think, on the day, which is something like 20% higher than it's ever been, which is quite extraordinary. And I also do want to thank again the McGregor team, who during June had some really challenging situations develop. So McGregor team, all of our frontline teams are heroes, but the McGregor team on McGregor particularly, big call out to you. Thank you very much. So just contextualizing some things that have happened in June, which I wanted to personally thank. Adam, over to you for the detail, please.
Thank you, Chair. Yeah, so I think the headline message from May actually was that we were incredibly busy. We did have our busiest days in ED, but as you just said, Russell, we actually surpassed them in June. Having said that, for the month overall, we had our highest ever number of ED attendances, and we also had our highest number of community 2-hour response referrals, which I think is a good thermometer for how busy we were during May. Of course, there were knock-on effects to that. So we had our STEC areas open overnight that we wouldn't normally have to support flow, and obviously that had a staffing and financial consequence, and you can see some of that as part of the report. We also saw a slight deterioration in some of our quality KPIs, which we're keeping under close surveillance, and Fiona may well talk more about those. But we are working to understand if that's a trend or a reflection on the capacity and demand challenges we had in May. In terms of the other performance indicators, elective performance remains good. We had no 78-week waiters, and as Glenn has said, we're participating in the Faster Further programme to exceed the national 65-week target and hit 52 weeks. And in many of our specialties, that's going well. Cancer performance, however, remains challenging, but there have been some improvements and an awful lot of work underway. And we also had a positive cancer quality visit led by the ICB a few weeks ago. And as has already been referenced, we continue to work with UHCW on that sustainable model for oncology services going forwards. Also during May, we saw some really positive improvements in our workforce indicators. So sickness and turnover were both down, but it was a really challenging month financially, and I know Kim will talk about that. So we have a current deficit against plan. At this stage, we don't believe it's an issue to be too worried about, and we think we will move back to plan. I think the contributing factors there were the profiling of the CIP schemes, which are divided into equal 12s, where we know actually the weighting of delivery is more towards the end of the financial year. However, I think it's important to also note we are seeing a financial impact from the strikes, which will continue with the strikes. I think those are the key messages I wanted to highlight, but I know my colleagues will dive into those in more detail.
That's great, Adam. So shall we go into the detail and tease out points as we go along? But any questions or perspectives to Adam as we get going, Glenn?
Yeah, just a point of emphasis, as Adam said, I think we are still a segment 1 provider, so we're in the top performing trusts nationally. There's two things that we just need to keep an eye on at the moment that could put that at risk. One is the financial position and trying to ensure that we do not go into deficit from a forecast perspective, and Kim will cover that off in a moment. Then the other one is the cancer performance issue. So working really closely with our colleagues at UHCW who deliver the consultant capacity, which is the constraining factor on that performance, to ensure that that doesn't cause us a performance issue. So the two things, just kind of a precursor for the detail we're about to go through, just to keep an eye on.
Points well made. Thank you, Glenn. Okay, we're going to the detail then, and starting off with quality and safety. Fiona, do you want to lead off, and then Charles will follow?
Yeah, thank you, Chair. So, Glenn, the other aspect of the SWFT that I've referred to in my report is the gram-negative bacteremia rate, which we are currently flagging as red against our SWFT rating on that as well. And that's really why I wanted to just give a little bit more assurance to board on that. So we're not, although we're flagging as red, it's not unusual compared to other organisations across nationally. This is a trend that we're seeing from COVID, that there is an increased rate of gram-negative bacteremias. We've got a very difficult and tight target set nationally, but I just wanted to give board and the public assurance that we have started an improvement plan. The start of that really is to do a deep dive into each of the cases in terms of the root cause of those infections, because I think it's fair to say IPC colleagues nationally are struggling to understand why there has been such a significant increase, and as I say, it is a national increase. So we will look at those individual cases in more detail and then target our improvement on those causes. So happy to take any other questions on that. In terms of the other areas of quality that have become strained this month, there's a slight increase in falls and a slight increase in medication safety errors. As Adam said, it's a bit early to know whether that just relates to the increased activity or whether we have got an ongoing trend there. So we are watching those carefully. Thank you.
Thank you. Thank you, Fiona. And Charles, anything you'd like to add to the quality and safety part of the IPR?
No, nothing to add.
Okay, thank you, Charles. As I said to members of the public, we did have a deep dive into mortality as a board this morning. Questions and perspectives to Fiona or Charles? What's worrying you most at the moment, Fiona?
I think the increase in acuity around mental health and cognitive impaired patients requiring additional support from staffing, I'd say, both in adults and children.
Okay, keep us briefed on that if you can, because as to whether that's a long-term trend or just a short-term issue that we're having to deal with. We'll move on then to operational performance issues. Harkamel, over to you.
Thank you. So as has already been said, we had a very busy May, and the 2nd of May actually saw our record number of attendances ever at 315. And when we did a bit of a deep dive, that increase was across paediatrics and the 18 to 40 bracket. And what was interesting was that the 41 to 74 age bracket was the one that was really driving admissions. And we haven't necessarily seen that trend in admissions before when we start to ramp up into the busier summer months. So what we're trying to do to move forward, given that we've continued to see a record number of attendances in June, and I do feel like I've said that a lot since I've got this job. Every time I come and do a presentation, it's always a record number of something, but it truly is. And I didn't include it in my report, but we also saw a record number of insect bites as a reason for patients coming to ED. So we're trying to use the data a bit more to try and inform what's coming in and what we can expect, so that we can do a lot more signposting more proactively. So I sort of said it in jest, but actually there are other pathways for patients with insect bites rather than coming straight to the ED, and it's really important that we do what we can to try and inform that. And we know what other reasons for admissions tend to peak over the summer, so we're thinking about how we can proactively signpost our patients so that they don't end up coming here, because our department clearly is not big enough to see the volume of patients that we saw in May, and then certainly not in June. And then there has been a knock-on in terms of some bad performance. From an elective recovery perspective, our elective recovery is still on the way, and we are still driving down our much longer waits. And as Glenn mentioned, our outpatient programme of work is really key to that. And in a few months' time, I'll be able to give an update on where we are with a further faster piece of work. I've said before that our diagnostic waits are increasing, so this is the largest number that we've ever had on our waiting list. We're doing a capacity and demand piece to try and map out how best we can close that gap between the demand on the service and the capacity that we have. But just to flag here that feels a little bit of a worry for me. From a cancer perspective, our 28-day faster diagnosis standard, we have a regional trajectory that we're expected to meet, and unfortunately we did miss that in May, but we will meet that in June. And so we're on trajectory to exceed our target, and we did meet the breach allocation that we had for the 62 days. So I think we've got quite good grip there, and we know, and we have agreed trajectories in place, and we're meeting regularly with NHS England for that. I included, as part of my focus slide, just a bit of an update on the Community Recovery Service. So this service commenced on the 22nd of April, and essentially the aim was to try and streamline some of the pathways so that we can discharge patients more quickly and more effectively. And although it's only been live for a couple of months, I thought it was really important to share with board members what we're trying to achieve here and like what some of the strengths have been. And so far, actually, it's been really good. I think we've learned quite a lot. We have seen a reduction in long-term packages, and we have seen a reduction in the time it takes from a referral for a package and then for the package to be in place, and quite a significant increase in the number of packages that have been able to start the next day. I think overall, though, we have seen an increase in the numbers of patients being referred for a request for a new package, and I think that's quite interesting. And it might be that we just didn't have very good signposting, or it might be in that that the system was far too complicated before. But whatever the reason, at least we now, we have a bit of an understanding of what that demand looks like. And the aim is to really refine the CRF service. And I've outlined the 6 work streams that we've got so that we're ready to winter to really hopefully feel the benefit of this piece of work. But that's all I wanted to share with you.
Thank you very much, Harkamal. Thank you for your hard work. Questions or perspectives to Harkamal? Sue.
Harkamal, hi. On oncology, thank you for providing the update around and others, colleagues mentioning some helpful progress, but still a sort of systemic issue in terms of demand and capacity. My understanding, I just want to check it with you, is that there are 2 different processes overseen by the system. One is a quality escalation process, and one is a service design review or redesign. Which one of those are we in? And when is the next paper available?
So we're in both. So the system have come to do a quality review here, which was really, really helpful actually. And they were really impressed by the service that we provide through the Aylesford, and we've encouraged our system colleagues to come and see what we do at Rigby so that they can fully understand like the offer to our patients. So from a quality perspective, in terms of the delivery of oncology treatment that we are responsible for here at SWFT, we are part of that, and we really welcome anyone who wants to visit, and that's an open offer. And we've had the first draft of the report now, which will be shared, and we've urged colleagues to go and visit George Eliot and UHCW so that there's a full system review, and I think that is ongoing. I don't think those visits have happened just yet. The wider issue with oncology is around the capacity, and as you say, it is that service. Well, yeah, it is the service, the design of the service, as in the issues that we're facing are entirely the outcome of the product that we have. So as I've explained before, our oncology appointments, so our first appointment with an oncologist after patients have been diagnosed with cancer, are provided by consultants from UHCW. And at the moment, we do not have sufficient oncology capacity for those patients. And that's why I talked before about that long wait that we've seen creep in for patients to see the oncologist, so that very first appointment. And then once they've seen the oncologist, should they be referred for chemotherapy, that happens relatively quickly, and we've sorted out the aseptic issues that I've explained before, or they'll be referred over to UHCW to receive their radiotherapy, which also happens relatively quickly. And the progress that we've made is to close a bit of that gap in terms of the length of time that patients are waiting. So we have had additional clinics provided. We've gone through on a patient level all the long waits and escalated that with system colleagues who've supported in expediting the appointments for those patients. So from my perspective, where we are now is that the waits are more acceptable. My concern is, and why we are keeping in our really strong governance between me and Charles and Fiona, is that post-summer, or even in the midst of summer, unless the capacity gap is permanently closed, we could end up in this situation again. The assurance I have is that we're meeting so regularly, and I have all of that data, and I'm providing it on such a regular basis, it shouldn't creep out again. And you know, we're absolutely not going to sort of take our foot off the gas in terms of like the escalation, but the solution that we have isn't yet a sustainable solution. But Charles, I don't know if you want to add to that.
Yes, I just put my hand up to add to it. I agree with absolutely everything you've said in terms of the quality escalation and you know, the approach. With regard to the review, I don't see that really addressing or changing the underlying problem, which is, you know, the mismatch between oncology clinical session availability and demand. There will be some skill mix solutions that we can apply, that we can see, but that review is perhaps more about whether specialized commissioning, with their devolvement of responsibility for oncology to system, is whether there's a change in the way it's commissioned. Because you know, our colleagues at UHCW, I think, have made no secret they would like to be lead provider for this, and that's something that you know, will have to be worked out in this review. But I don't think it will change or really address the issues we're looking at.
Yes, I agree with that, Charles. I don't see how changing to a lead provider model in any way increases the capacity of oncologists we have in the system. So I think it is important for, if that is being proposed, that a very clear elucidation of why that will increase capacity is made. Just before I invite you back in, Harper, it's also why I strongly encourage our system colleagues to look at procuring private sector oncology consultancy sessions to reduce the waiting lists for people who are waiting for to see an oncologist. The reality is, in Coventry and Warwickshire, private oncology sessions are provided by the consultants that are employed by the UHCW, effectively, doing their private work. But I thought, rather than allowing rich people to be able to get faster access into an oncologist, I prefer our system, the ICS, to basically procure those extra sessions and apply them to NHS patients waiting on our list. Harkimer, your hand went down again.
Well, I was going to make a point that may be a bit pedantic, but it's just to sort of say the lead provider model isn't different to what we've got now. At the moment, we have an SLA with a provider that is the lead for employing all of the oncologists, and then we bet them buy that service. And I think it really is that basic. And I think that's the bit that we need to start from there and then think about how can we make this better so that all patients receive the same, are seen within the same waiting time, are part of the same pathways, are subject to the same clinical standards, and that there is no exception. But changing the model of provision doesn't increase the number of oncologists.
No, absolutely. I'll allow Glenn to come in, then we'll move on. Glenn?
Yeah, actually, I was going to say something. You could argue the lead provider model is not working. So I think we do need to look at potentially a more devolved model. Our colleagues in Worcester Acute actually employ their own oncologists, and that does seem to have been a better way of securing more flexible capacity. So we're certainly up for having those kinds of discussions. Pleased to see we now have mechanism in place to balance the capacity across the system better, so that patients are not waiting any longer in South Warwickshire than other parts of the system. And I'm also pleased that we seem to now be actively recruiting to additional posts. UHW taking that forward, so that's good to see. The other thing I'd just come back in, just to kind of close the discussion, Russell, is obviously we've gone into an acute discussion about cancer waiting times, quite rightly, because the risk there. But it's great to see the community recovery service stats. We've got some fantastic out of hospital teams, and to see that the work they're doing to put in place that kind of vision that we have to deliver care close to home is really encouraging.
That's exactly the point I was going to make, Glenn. I think Becky Howe isn't on the call with us, but Becky Howe's been intimately involved in this, and it's, as you say, Harkemel, really helping flow and making things easier than otherwise it would. Okay, colleagues, if there are no other points to Harkemel, we will move on to our workforce. Now, Gertie isn't with us, so I'll take the report as read and drop Alan in it if anyone's got any questions or perspectives. So any questions or perspectives on the workforce part of our report? Okay, apologies, Adam, but it's a prerogative of the chairman to drop managing directors in it. And how are you feeling about the work we're doing on the pace of our progress on recruitment and retention?
So I think there's been some real focus on the time to recruit in particular, and we've seen over the last 12 months a really significant drop in the time between advertising a job and making an unconditional offer for a job, which is positive because it's getting people through the system quicker. I think the area of workforce I'm most worried about, and this crosses into some of the other areas of reporting, is the use of agency staff. And I think we're still not seeing recruitment of roles, which is good, translating into reduction of agency spend in a big way. Now that might be a time lag issue, because I think there's some areas where we've done substantial recruitment, like ED, where those roles will only just be coming online and potentially be supernumerary at the moment. So I think we will see some improvement over the coming months, but what we've committed to do over the coming weeks is a deep dive into our reasons for agency spend and really assure ourselves that we're recruiting where we should be recruiting to address that.
That's exactly the point I wanted you to extract. Thank you, Adam. I think the aspect, I'm very conscious, for example, Harkemel, with the pressure in ED, when we're seeing such a high volume, the team need all the support we can give them. But it would be good to see the results of that deep dive. Okay, if there are no other comments then on the workforce part of the report, I'll move on to Kim. Kim, over to you. A tough start to the year.
Yeah. So I think Adam summed it up. I mean, it's reflective, really. I think of three key issues. We've got a bit of expenditure that we've incurred on the back of the industrial action that took place in April. That's not something that we've been funded for, and we're expected to manage that. And indeed, that's what we're looking at in terms of mitigations to ensure that we manage that expenditure moving forward, to ensure that we deliver our financial plan of break even by the end of the financial year. The other aspect is around really a reflection of the operational pressures that we've experienced in the last couple of months. And the fact that there is probably a timing lag in terms of the seeing the impact of our recruitment and really seeing the agency reduction that we were hoping. So agencies is a driver to the position. We did set some challenging reduced profile targets really for the divisions, but it's higher in months than we would like. So we just need to to do a deep dive to understand what the key drivers are and ensure that we take action to get those back on track really for the rest of the year. And the third aspect is around the CPIC delivery, which we talked about, the phasing of those, and therefore the expectation is that although I've put a challenging expectation to deliver those, you know, early on in the year, the reality is that, you know, because of the timing of plans coming to fruition, that we won't see some of that until later. But we continue to drive through those savings, you know, to deliver those earlier to FMP, and we're, you know, again supporting the divisions to ensure that we're managing well, we're supporting them to manage their financial position on a monthly basis. So that continues to be the focus really of our finance and performance executive meetings. But as Glenn alluded to, you know, we, you know, at this point in time, you know, remain confident that we will, you know, achieve the CIP programme. There's work to do, but actually I think we've got, you know, some really good engagement, and we've got a number of plans that we've been working on behind the scenes that probably haven't quite made it onto the template at the moment, but indeed a lot of work going on behind the scenes. So at this point in time, I think we are off track, but we've got you know, plans in place to get us back on track to ensure that we deliver the financial outturn of break even. The other thing I just wanted to bring to the attention of the board really is just for the members of the public, it's just to let them know where we are with last year's position, and that's just to confirm that we've received a clean audit opinion in respect of last year's accounts, and that the audit was signed off on Friday and uploaded to NHS England's portal according to the deadline. We were one of you know, a few organisations actually that managed to hit that deadline. So wanted to formally you know, note my thanks really to my team, but also the auditors who helped really to ensure that we hit that deadline. Still waiting for the final audit certificate and the value for money report, which we're expecting in the next couple of days, but no issues expected on that front. I think those are the key things that I wanted to update the board on. I'm happy to take questions.
Thank you. Just before I invite questions, well done to you and your team on the audit situation, and Richard, as chair of the audit committee, thank you for the support I know you've been given behind the scenes. Any questions or perspectives to Kim on the numbers? Okay, look forward to the progress going on. That segues nicely into the Excel in Everything work. Sarah, do you want to give us your update, please?
Thank you. So as the paper outlines, the team's made some really great progress since last month, and as Kim's just said, it's really encouraging to see that there's significantly more work in the pipeline. I think it's only right for me to highlight Kim's point, though, that we will need to keep up the smart focus to ensure that we're confident of delivering our ambitions by year end. So at the end of month 2, we were confident of achieving just under 6 million budget reduction savings, and I have plans for over £4 million of run rate reductions and some additional productivity savings. But as we discussed, and as we discussed in our board workshop this morning, the budget reduction figure is conservative at this stage, and I think that's the right approach, that we only add financial trajectories into what we're reporting when we're really confident they're going to deliver. So there's over 100 schemes that are being overseen by the Project Management Office, and we are seeing many staff come forward with more ideas which they're taking forward, lots of patient-focused quick wins that will also help to make us more efficient. But we are currently reviewing the schemes in terms of potential delivery to ensure that we do have sufficient focus on the work that will deliver the high value, both in terms of finance and quality improvements. In terms of risks, we've already discussed several times, but it's only right that I say that the medical agency and locum work stream is as already reported, significantly off track against planned savings. Our run rate reduction programmes do cut across all the work streams, and therefore they are key to the success of each work stream. So there's definitely some significant work we need to do over the next month around those to pull those back on track, as Kim has said. So just to end with a real positive, this month's report has got more detail on our out of hospital division, and I'd like to take this opportunity to congratulate them because they have really made some excellent progress so far.
No, it's
Thank you.
great piece of work that's going on generally across the organisation on Excel. So well done, Sarah, for your leadership, and Kim and everyone's involvement in it. Any questions to Sarah on the Excel in Everything programme? I do think it's creating a sort of a snowball effect, and I'm really looking forward to seeing the way that builds over the year. So we'll move then on to the capital programme quarterly update report. We are just running a few minutes behind, but Sophie, over to you.
Thank you. So just to note really that there are some really large schemes that we're managing at the Trust at the moment, continues to disrupt the site and the experience for people. And so I guess through board meetings continue to apologise and thank everyone for their support with that. But what we're trying to do is put assets in place for future generations. So these are big, large scale programmes of work that are complex, and through the reports we'll bring out some of the risks that board need to be aware of. We're currently undertaking an exercise to update the unfunded list, which you'll see as part of one of the appendices. This is going to be really key because as we work through the year, we need really accurate reporting in terms of our forecasting so that we can move around funds and prioritise our unfunded list to maximise our opportunity. That being said, there will be things that we can't do. And again, through management board and board, we'll make sure we're highlighting that and any risk we're carrying with that. And my final point really sitting alongside this is just the piece of work we're doing around asset utilisation. So this capital report is about investing in our capital, but that has to go hand in hand with making sure we're maximising the use of it. So that's quite a key piece of work we're doing through the Excel in Everything programme as well, about a work stream that looks at some of the utilisation on our estate. I'm happy to take any questions, but projects are progressing well. The partnership with Warwickshire County Council, they're really helping us at the moment when we're getting into sticking points on our programmes. They're working with us. So it's a big thanks to the County Council as well, because they are really supportive of the programme and helping us to move quite quickly, actually.
Thank you, Sophie. I know it's an incredibly complicated series of projects that are going on, so well done you and your team. And again, just to reiterate, the board's apology to members of the public who are struggling to park on occasion. We recognise the practical challenges on certain days of getting onto the site, but it is unfortunately a necessary part of us investing and changing things for the long-term betterment of us all. Questions on perspectives to Sophie? Keep up the good work, and great to see, and thanks to Mary Powell in particular on this and her team, the increase in communication to try and help members of the public on a daily basis on issues going on the site. We'll therefore move on to the 7-day working annual compliance report, and I see Rachel Dancer with us as well. But Charles, are you just going to segue into Rachel, or how are you going to do this?
Well, I was going to do a few words of introduction, really. That this is a report that has been modified in terms of the standards, which really we could just report structures in place, but because this is so important, we've gone a little bit further and actually done some audit on standard 2, because senior decision making is so important to flow. And we've got some detail in a time when we're really very busy, and Rachel did that audit, and I'll hand over to her on that. There are some other less important standards that I'll report at a future meeting, but also I hope to look into the actual application of them rather than just saying the service exists. And one of those, for example, is mental health. And we could say there is an AMHAT service, but given the issues we have with it, I think some information on how it's actually performing would add to the richness of it. But over to Rachel in terms of the audit that they performed in acute medicine.
Rachel, over to you.
Thank you, and thanks for inviting me to this meeting. So I'm, just for people who don't know me, I'm Rachel Dance. I'm one of the consultants for the acute medicine department, and as part of the national acute medicine strategy, every year we've been taking part in the SAMBA audit, which stands for the Society for Acute Medicine Benchmarking Audit. And last year in June 22, 155 acute medicine units across the country took part in the audit, and as a result of our participation in that, we receive a report whereby we can benchmark our performance against other acute medical units across the country. We were delighted when we got the results of that to find that we were performing above average in all the parameters that were looked at, including patients having their observations checked within 30 minutes of arrival in the hospital, the time it takes for patients to be seen by any clinician and have that first medical clerk in, and also the time it takes patients to be seen by a senior decision maker, the consultant on the post-take ward round. As Charles said, for that standard 2, looking at how long it takes patients to see a senior decision maker, that's a very important standard for us to meet, and also the targets for that are very challenging. So where patients are admitted during daytime hours, which is defined as 8 AM to 8 PM, the standard is for patients to be seen within 6 hours of admission. If patients arrive between 8 PM and 8 AM, so overnight, the standard is then 14 hours, which is a little easier to meet. And across the country, in the June 22 SAMBA audit, the median performance for the daytime senior decision maker was 42%. And here at SWFT, we achieved that target for 70% of patients. So we were doing far above average for that one Thursday in June. So when I reported these results to the team and to our division, I was then asked, okay, but what about at the weekend? And so to investigate this, we looked at a weekend in February and used the parameters that we use for SAMBA, but to do our own internal audit. And we looked at a Friday, Saturday and Sunday in February and found that actually our performance is good there as well, but that particularly with it being a February, our performance compared with June was a little lower. And on Saturday and Sunday, for patients arriving in daytime hours, we do struggle to see those patients within that challenging 6-hour target. Our plan is to discuss that at consultant meetings and come up with a plan as to how we can address that and how we can look to have patients see a consultant earlier. I think there are a number of issues that lead into that. One thing that we noticed from looking at the data is that on a Friday, roughly half our patients are referred direct to medicine from GP surgeries and areas like that, whereas at the weekend, all of the patients we see pretty much come through the emergency department. And the way that we work out the admission time for patients is the time of arrival at the hospital. So patients who have seen a GP already come directly to medicine and have less steps before they see a consultant than patients who come via emergency. And that means that then at the weekend, all of the patients have that extra step and that lengthens the time. And that's something that we'll be looking at as well. I'm happy to answer any questions about what we did and anything like that. And I hope that's been useful.
No, really interesting, Rachel, and thank you for all your hard work on it. Glenn?
Yeah, thank you, Rachel. It's good to see the level of performance that we've kind of would have expected of our urgent care services here. The bit I didn't quite understand though is on page 4 of the report, the second part of the table, when we talk about thrombosis, thrombectomy, and PCI. I thought we would be ticking the middle column there, that they're available via network rather than not available. Am I misreading that?
I might hand over to Charles for this bit.
Yeah, that's right. That you are misreading it, or it's the wrong box is ticked, but it is available via network.
Thank you, Charles. So I think you're saying I'm right, Charles. Thank you.
You're right. You're right.
Thank you.
And any other questions or perspectives? Okay, Rachel, keep up the great work. Thank you. It's very helpful. I look forward to the next update. And so we'll move on then to the Digital Health Board quarterly report. Adam.
Thanks, Chair. Just 3 points I want to highlight. I think firstly, a significant focus remains on the EPR. And just to note for board members that we're anticipating the final review by NHS England this month, which will allow us to move ahead. We await the signing of a final MOU with UHCW, which I think they are reviewing this month, and that will allow us to sign a contract with the supplier next month. Secondly, I wanted to point to the significant implementation work that our IT teams are doing. So we had the Viewpoint fetal scanning system implemented over the last few months, which has significant benefits for maternity in terms of quality and productivity. We've also got plans with EMIS. So we are commencing implementation of EMIS with Myton Hospice. And we heard this morning about the need to implement EMIS in community children's services, the case and plan for which are currently being developed. Finally, I wanted to highlight the great work done on the ICR. So the Integrated Care Record is now in use and bringing together care information from providers across Coventry and Warwickshire. And over the last month, pathology and radiology data has been included into that. So that's great progress in having that single record across the ICS that we've been looking for and hoping for years.
Great, thank you, Adam. Any questions to Adam on the Digital Health Board update? Be great to help out those community teams. Adam, Sue?
Yeah, Adam, and wondered if you could send me under separate cover the Digital Hub new strategy, because I'd be interested in that and others might be. And on EPR, I realise that there's a point in which there will be a substantial draw on operational staff and clinical staff in order to sign off essentially the functionality for their service in the build. Am I right that that starts kicking in the next month or so, and is there assurance that the teams are ready and resourced for that?
So the work proper begins next March. So we've got some run-up time. What will start in the next month or so is the recruitment into roles. So people won't actually be doing those roles yet, but getting names in the frames, organising backfill where required is the hefty work that's starting imminently.
Thank you.
Thanks, Sue. Thank you, Adam. And Charles?
Yeah, I mean, Sue makes a very important point, and you know, the ability to backfill may be difficult in some of these areas. So we're trying to work smartly and identify people who can be backfilled, rather than, you know, give roles to people who then we find creates a problem. But it is an issue.
Okay, thanks, Charles. Okay, team, we'll move on then to the Audit Committee report for the 7th of June. Richard, anything you'd like to put out? Richard, you're on mute.
I thought I'd knocked it off. Sorry, I've done it once, but not again. Take it as read. We had 2 meetings in June. We had the first one to go through the draft accounts on the 7th of June. A couple of internal audit reports there, which were one had moderate assurance, but that's because we were waiting for the external provider to give us their assurance, and then the payroll was good. The accounts we've talked about earlier, and I just congratulate the accounts team for 2 reasons. One, we were just the right side of break even, and they delivered very well, and Suban really helped getting the report out early, and that was well cleared. So we've done all of that. And the only other thing was Sue's also helped with upping the number of returns on managing conflicts of interest and gifts for hospitality. We're up to 74%, which is a significant increase on the previous last 6 months.
Thank you, Richard. Any questions to Richard? Richard, thank you, and thank you for every member of the Audit Committee for their work. We'll move on then to the Clinical Governance Committee report from the 14th of June. David, anything you'd like to put out?
I don't think so. I think I'd like the report taken as read, and I'll invite any questions from anybody.
Thank you, David. Any questions or perspectives to David? Thank you, David. I'd just like to thank you because I know you've been involved with some system-wide discussion on this issue of oncology differential performance. So thank you for your continued endeavours on that.
Thank you.
And then we'll move on therefore to the Foundation Group Strategy Committee report for the 23rd of May. Simon, anything you'd like to particularly emphasise?
Thank you, Chair. Like David, I'm happy to take the report as read and invite any questions.
Great, thank you. Any questions to Simon on that report? I would just like to remind members of the public that the next board in August is a 3-board meeting in the Foundation Group. Those members of the public who have attended them before, the feedback they've given me is they find them very useful as a basis for comparing and contrasting the performance across the different bits of the Foundation Group. So members of the public warmly invited to that session. We'll move on then to risk management and the board assurance framework and risk quarterly report. Adam, back with you.
A few points. So the report highlights is the board assurance framework for last year and the end of year position. 2 risks remained from the BAF, which have now been transferred to the relevant risk registers. In terms of the BAF this year, it is highlighted on the report. Execs have been assigned to each of the objectives within the board assurance framework, and we're currently just finalising the measures and the risks associated with each. They will be reported along with progress on those to the imminent Council of Governors meeting. Finally, the report highlights the red risks currently on risk registers, which are being managed through the divisional risk management boards. I will take the rest of the report as read.
Thank you, Adam. Questions or perspectives to Adam on either the BAF or the risk quarterly report? Adam, I guess a question from me, because we have seen in the first quarter phenomenal increases in ED demand. Do we think we're getting the risk level right from that continuing at that level? Just thinking as we hit winter, can I just ask you to take that away and reflect on whether we're sort of appropriately identifying that as a risk? Either we've had a blip or we've got a new trend, and I think the consequences of each are pretty significant. Either, you know, particularly if it's a new trend. My fear is it's a new trend, and I would just like to say to members of the public, it's an accident and emergency department, an urgent emergency care department. If you have something like an insect bite, please either Google can be your friend on occasion, or certainly go to a pharmacist before you come to our ED department for an insect bite. Every single visit to an ED department costs in excess of £100 per visit. That is an extremely expensive way of getting some pretty straightforward advice from a pharmacist who will give you that advice as to the medication required free of charge at a pharmacy close to you. As much as we aim to help you as citizens of Warwickshire to get the best possible levels of service, we do need you to help us to use our services appropriately. Colleagues, happy to move on. Back with you, Adam, for the summary of ratified policies.
Yes, I'll take the report as read. There were 3 policies ratified, all of which were updates to existing policies for regulatory changes and similar.
Okay, great. Thank you. Any questions on the summary of ratified policies, colleagues? Okay, duly noted. Thank you, Adam. Then we've got the Health and Safety Annual Report. Harkamel.
Thank you. The only thing I wanted to pull out is just the assurance around the Entonox survey that we were required to do. So we did do a survey on the Entonox levels in maternity, which was following a flag from the CQC, and our audit did show that we are within safe levels. But given that the sample time of the survey was quite short, we've commissioned an external company to come and help us and give us some further assurance on the air quality over a 3-month period. So I will feed back if there's anything that we need to do in line of that. And then I've also included the local security management annual report, and that outlines that we've had an increase in violence and verbal abuse and harassment, and it's up 74 cases compared to last year. And just to note that the increase for that is with regard to physical assault. There are a number of actions that we've put in the paper to ensure that our staff feel safe and are assured about escalating and making sure that they know that they'll get the support that they need. And a number of that is local solutions as well as additional training. And I just sort of wanted to say that we remain committed to ensuring that our staff are in a safe environment, and we're working with partners to make sure that we are fully wrapping around this issue and tackling it sort of head on.
Thank you very much, Harkema. Any questions or perspectives to Harkema? Just like I was going to make that very point, Harkema. I mean, a third of our staff, according to the staff survey, have experienced harassment or bullying from members of the public. That is wholly unacceptable. It is not fair for people in our wonderful NHS to experience intimidation from members of the public when they're doing their utmost to try and look after them. Again, as I said, much as we have a responsibility to members of the public to provide the best possible care we can, members of the public have a responsibility to act in an appropriate, polite and respectful manner to our staff. Our staff are not employed to act in a way which, or to have to respond and take on board physical or verbal abuse. I'd also like to have a big shout out to our security staff, who are often unsung heroes when physical intimidation is coming from a member of the public. So if you can pass on our thanks as a board to our security teams, that would be greatly appreciated, Harkema. Thank you. Colleagues, happy to move on then to the board committee minutes. And the first is the audit committee of the 12th of April. Anything you wanted to add, Richard? Richard, you're on mute again.
I'm on mute. Don't take me ages to get my mouse over there. No, nothing to add. It's taken as read.
Thank you very much, Richard. Any questions or perspectives to Richard on those? And therefore, we've got the clinical governance of the 10th of May. David, anything you'd like to add to those?
No, nothing I need to add.
Thank you. Anything from colleagues? So I think then, friends, we're on to any other business. Could you please raise a digital hand if you have any other business? Okay, so we'll move on then to if any members of the public have any questions for us. Sarah, have we had any questions provided?
We have, Russell. We've had 2 questions from 2 governors. The first is from Mary Malloy, Public Governor for West Stratford and Borders. So Mary's asked if we can explain the relationship between the Matron unit and the community eye service. I think Harkema is going to answer this question.
Thank you, Harkema. Thank you, Sarah. Thank you, Mary.
So I think there's a lot of work that's ongoing, and what I would propose is that I'd bring back a detailed update of ophthalmology, because what we've seen is an increase in requests for an understanding of what our community pathways look like. And whilst we don't have responsibility for that, I can appreciate from a patient perspective, not understanding how to navigate through that does add to a level of complexity and just that feeling of uncertainty. So if that would be okay, I'll bring that back as a form of update to my next IPR. Okay,
that would be great, Harkema. Just conscious of the fact that we are meeting as a board again next in September. Could you maybe drop Mary Malloy a note over the next few weeks so that it doesn't get lost in, won't get lost in the annals of time, but we just address it with pace. I think part of the anxiety is what's the contractual relationship as well as the pathway. Thanks. The second question.
This is from David G, the Public Governor from East Stratford and Borders. So David recently watched an online play/tribe presentation. Whilst impressive, the tribe presentation has the same problem with which he's experienced in the past. In particular, it created a website downwards without considering older patients who do not have electronic accessibility. As this group generally will have a greater need for such help, such an omission is not acceptable. Too many will not have helpers and their fingers may be too arthritic to use a pad, even if supplied. They will, however, have a telephone available with larger, easier used keyboards. The Trust has also been similarly guilty in the past with some of their projects. And David therefore asked the board to ensure that all future facilities, both third party and internally developed fully consider this important group.
No, I think that's a fair challenge. Was anyone going to address it immediately, Sarah? Adam?
Yeah, I do think it's a fair point, and we do really need to consider digital exclusion when we're implementing something new. Having said that, I think that Tribe is a really good example of a project we're doing where we're trying to build in the needs, particularly of communities who wouldn't traditionally use digital devices. It's a small pilot by a company called Bronze Labs, who've done a lot of work on accessibility. They're specifically testing it in stakeholder groups with carers and older people, and assistants being piloted. And this is exactly the kind of feedback that we're looking for from the pilot to understand other options of accessing the information when they're available. I think David's feedback is important to consider in that, and we will continue to do so. I do think it's important that we don't not take digital options though, because they do allow and enable us to do things that we couldn't do in traditional means. What we need to make sure is we've got those backup options for people who may not be able to access them.
Okay, that's great. Thank you, Adam. And keep us briefed on that. I think the issue of effectively digital exclusion through digital anxiety is something we need to watch, but I know you're alive to that. Any other questions from members of the public? Okay, I can't see any digital hands going up, so I will therefore draw the meeting to a close and say I hope you're able to join us at the next Foundation Group 3 board meeting on the 2nd of August. And in the meantime, as we enter the summer period, if you're going on holiday, members of the public, I hope you have a lovely time. Avoid those insect bites. And if you do get an insect bite, please go to a pharmacist, not to your local emergency department, but I'm sure none of you would. For board colleagues, I suggest we have a 10-minute comfort break and meet again at 3:30 for the confidential board. Thank you. Bye-bye.